So first of all, good afternoon, everyone, and thank you all for joining us today for our second Outcomes for Me webinar in the Ask the Expert series. Today, we have the pleasure to welcome breast oncologist, Dr. Terry Mulvey from Mass General Hospital, joining us to discuss what you should know from the front lines of this pandemic. My name is Maya Saeed, and I'm the co-founder and CEO of Outcomes for Me. Outcomes for Me created an app to help and empower breast cancer patients with the tools and resources to better navigate their care. The format of today's discussion will be one-part discussion and one-part Q&A. We have gotten a few questions from our users prior to this webinar, but we encourage you to send us questions via Zoom, and we will do our best to get them answers during our time together. I want to start off by allowing Dr. Mulvey to give us a brief introduction about yourself, and then we will jump right into the discussion on the current state of this pandemic. Please, Dr. Mulvey.
Great, thank you, Maya. So as Maya said, I'm Terry Mulvey. I'm a breast oncologist at Mass General. I've been a breast oncologist pretty much my entire career. I've worked both in academics and in the community. In my current role, I'm also the Director of Quality and Safety for Mass General Hospital and for their community network affiliates.
Great, thank you very much. So to get things kicked off, Dr. Mulvey, we'd love for you to tell us what you are currently hearing, seeing, and feel breast cancer patients need to know from the front lines of the pandemic.
Right. Well, there have been lots of changes because of the pandemic. The most important one that most patients who have any appointments or have interfaced with the healthcare system at all have noticed that we're trying to keep people out of the clinic. We're trying to do as many visits virtually, either through platforms like Zoom, which we're on now, or Doximity, or your health system may have its own platform, so that we can see patients, talk with them, find out what's happening with them, and keep them away from the clinic. Alternatively, because of the President's First CARES Act, which was signed now almost 2 weeks ago, we can also do telephone visits with patients as well. There are some constraints with doing this, namely that some states don't allow reciprocity across state lines for new patients. We are able to do virtual visits, either telephone or video visits, with established patients across state lines. But if you live like in Massachusetts, where our state is fairly small and people cross the borders all the time from New Hampshire, Rhode Island, and Connecticut, this has posed a little bit of a burden on new patients seeking care. We're not able to do these platforms across state lines.
Oh, interesting. I didn't know that. So that means, would that mean that actually a patient that's in another state cannot do that with another physician in another state?
So we can have as many conversations and practice medicine the way we normally do, as long as we have an established relationship with that patient. If it's a new patient seeking a second opinion, then they do have to be seen in person. Whereas a new patient who is physically in Massachusetts, where I'm in Massachusetts, I can actually do a new patient visit through a platform like Zoom.
Okay, I did not know that.
It varies state to state across the country.
It's interesting, very interesting. So another question, just in general, just to set the frame, what in your experience misconceptions are you finding breast cancer patients are having from the pandemic that you want to help get clarified to our audience today?
Well, I think that the biggest one is that your breast cancer diagnosis, if you have been treated for cure and you are on either no therapy and your treatment was in the past, or you're on endocrine therapy, drugs like tamoxifen, anastrozole, letrozole, exemestane, you are not immunosuppressed. And so your cancer, your prior cancer diagnosis, which was treated for cure, does not increase your risk for a poor outcome from COVID. Certainly, patients who are undergoing active cancer treatment, either they're going through curative intent treatment now with chemotherapy, or immunotherapy, or HER2-directed therapy, patients recently finished with radiation, or patients with advanced cancer on ongoing therapy, they do have an underlying condition which would make their outcome from COVID less favorable.
So picking up on this, I mean, this pandemic have hit all of us in many ways. For those people that have a diagnosis of breast cancer patients and have found themselves diagnosed with COVID, any differences in terms of whether they should be treated differently from normal from COVID-19 patients that do not have a history of breast cancer?
So in patients who have been diagnosed with COVID, and let me first step back and say we have very little information about breast cancer patients and COVID. And what we have is primarily out of China and Italy. And we know that patients with advanced cancer, particularly lung cancer patients, have a very poor outcome when they're infected with COVID. Breast cancer patients, we have far fewer data to rely on. And in large part, I think it's because as soon as social distancing was put in place, breast cancer patients, like many other people, really took that to heart. And their infection rate is quite low. We have not had any staff in the cancer center who have been working only in the cancer center have issues with large numbers of patients infected with COVID, nor have we had large numbers of staff working in the clinics themselves affected by COVID. So I think that people have really taken the social distancing to heart, and they've been incredibly careful. Now, that being said, there are patients with breast cancer who have tested positive for the coronavirus. And those patients we treat like anybody else. We essentially, if they're on non-immunosuppressive medications like anastrozole or tamoxifen, we can tell them to continue taking that medication. If they're on intravenous chemotherapy, we do the same thing we would do as if they had pneumonia or influenza or any other kind of infection. We let them recover from their infection, and when they've recovered from their infection, we resume their chemotherapy. But we don't continue chemotherapy when people develop, serious infections of any kind, COVID or not COVID.
Okay, no, that's good to know. Now, unfortunately, cancer doesn't stop or, doesn't social distance in that context. And so some people in our audience have just recently been diagnosed with breast cancer. So what would you advise those people that essentially have a newly diagnosed breast cancer right as this pandemic is hitting right now?
Right. So there have been some substantial changes. So first off, if you were unfortunate to be diagnosed with breast cancer just as the pandemic began, there have been significant changes in the way we're managing early stage disease. Women with non-invasive disease, DCIS, their surgeries are being delayed. We know from a variety of studies that this is a very safe thing to do, to delay surgery almost as long as 6 months. We actually have a very large study open in Boston looking at the natural history of non-invasive breast cancer, where women are randomly assigned to surgery and usual treatment or no surgery at all. So we feel that this is a very safe thing to do, to delay surgery until such time as elective surgeries are opened up. And this truly is an elective procedure insofar as it's not emergent. There's not going to be a bowel obstruction or obstruction of an airway, those kind of surgeries which are emergent. For women who are diagnosed with early stage estrogen sensitive breast cancer or HER2 amplified breast cancer, we are giving them upfront treatment, either an oral endocrine therapy like tamoxifen or anastrozole, or a HER2 directed therapy prior to their surgery. Again, we have tons of evidence that this is a very safe thing to do with women with advanced breast cancer, and it is standard of care for women with advanced breast cancer. So doing this in women with very early stage breast cancer diagnosed on a core biopsy and radiology, this is a very safe way to approach them. It keeps them out of the hospital by and large, and it limits their contact with the health system. And it allows us to put the surgery on at a time when elective surgeries will be opened up again. Women with triple negative breast cancer really can't wait. And those women are proceeding to surgery and the usual way. This is an area where we really feel that those women can go to surgery. Fourth group of women would be women that were already on some sort of endocrine therapy or chemotherapy in anticipation of having surgery because they had a tumor that was too large to be removed, or the combination of their surgeon and medical oncologist felt that it was appropriate for them to have what we call neoadjuvant therapy. Those people too are still going to surgery, although we know with endocrine sensitive or estrogen positive breast cancer, you can extend the neoadjuvant endocrine therapy up to 1 year without any adverse outcome. Now, just a quick mention about why breast cancer surgery may be considered an elective surgery. We are using well, there's three reasons. We're using the equipment in the operating rooms as ventilators for patients who need respiratory support. They would die without these ventilators with coronavirus. So that's one reason. The second is the people running our ICUs, by and large, are critical care specialists and anesthesiologists. So that manpower has been redeployed to those people who are on ventilators. And lastly is the PPE issue. And this has been a difficult issue for patients, particularly those patients going to surgery who want bilateral mastectomies. And we've had to very carefully explain that removing a healthy breast, even though that woman wants to have bilateral mastectomies, is not something that is an elective procedure. There isn't a cancer in that breast. And it increases the operating room time. And when the first breast is done for surgery, everyone has to deglove, and regown and reglove. So it's a PPE issue. So it's the time in the OR, it's a manpower issue, and it's a PPE issue. And right now, patients are having to be delayed having their contralateral mastectomy, and that's been a big change.
Okay, thank you. Actually, we did get a couple questions live now. One of them, I'm going to read it. Whoever asked it, I believe we already answered it, but if that person feels it hasn't, please send a clarifying question. So the question is, what about patients who are having their treatment stopped, traveling, shopping for resumption of treatment in areas that are still doing surgery? What do you advise? So I assume it was difficult for me to understand the question. Perhaps the person is trying to understand if the treatment is stopped and in other areas of the country, they could elect to go and have surgery. I don't know if that's the way the question was intended. Would you advise them to actually make the effort and go somewhere?
I wouldn't. I don't think there's any place in the country, whether they're open for business or not, that is not affected by coronavirus. And this week, next week, and the week after, across the country, we're going to see a surge. So as an example, you can look on the Mass General website today and see that of our 900 inpatient beds, nearly 400 are filled with patients who are COVID positive, and an additional 100 are in the intensive care unit setting on ventilators. So we are at near surge, and this is going to happen across the country in community hospitals and academic medical centers. So I would stick with the team of physicians that you've put in place at the beginning. There are multiple options to delay surgery that will not result in adverse outcomes. And in fact, there is data from Europe that women who are taking endocrine therapy, tamoxifen, anastrozole, letrozole, drugs like that, who are on them for several months prior to surgery may have a better outcome. And so even though the usual is to go to surgery and then put people on these drugs after, there may be some biologic reason to do these drugs prior to surgery. So I would not shop around. I think you run the risk of losing your team who knows you, who's put together a multidisciplinary plan, and you're not going to outrun COVID. I think that those weeks were several weeks ago, but today it's not going to happen.
Okay. Also related to that is a question we received ahead of time, and I'm going to read the question as received. With the COVID-19 pandemic, my surgery scheduled in March was postponed. Is there any estimate when surgery for stage 1 cancer might begin once the current situation ends? And actually, that's even a broader question around, all these surgeries being postponed. Once the pandemic is over, are we going to have a surge in terms of all these surgeries that need to happen?
So that's a very good question. And that is a question I would put to your medical and surgical oncologist. Every institution and organization is managing it differently. Some are making a list of patients that have been delayed and prioritizing oncologic surgery over orthopedic surgery or other surgeries. But I think that it varies place to place, and that is a very reasonable question to ask your medical oncologist and surgical oncologist. And the answer is yes, we are going to have a surge. And the other thing we're seeing this week is we normally run several multidisciplinary clinics for newly diagnosed patients every week. We don't need as many because we've stopped doing screening mammograms. So there will be a surge in screening mammograms and a surge in new diagnoses of breast cancer when this happens. So people who are already diagnosed obviously have priority over newly diagnosed patients, but we're triaging them based on the stage of the tumor and what options we have to delay surgery. Now, to put this in perspective, at very busy centers, from the time women are diagnosed with a core biopsy till they get to surgery with stage 1 low-risk cancers, estrogen-sensitive tumors, things like that, can often be up to 6 to 8 weeks because they're busy places. So a delay, although it seems so terrible to you as an individual, it's really important that you talk to your healthcare providers about what this delay means for you. And like I said, triple negative breast cancers, they're moving through.
Great, thank you. Another question we got actually through the live stream, and please feel free to submit the question via the Q&A button. Any recommendations for nursing working in healthcare who are over a year out of treatment for breast cancer? I know at the beginning you said, that's pretty safe. Any specific considerations?
So if you were treated for cure and you are not on any immunosuppressive chemotherapy, your risk of getting COVID has nothing to do with your breast cancer diagnosis. It has to do with social distancing, using the proper PPE in a healthcare setting, and where in the healthcare setting you work. But if you were to get COVID or coronavirus, your outcome would be the same if you're on an endocrine therapy and you're more than several months after your last chemotherapy. You are not immunosuppressed at this time. Now, if you're continuing to get ongoing immunotherapy or some sort of chemotherapy, then yes, you are at risk. And many institutions across the country have implemented work restrictions for patients for staff who are immunosuppressed from all kinds of diseases, rheumatologic diseases, underlying other cancers, underlying heart disease. And I would encourage you to speak to your occupational health person at your job or at your hospital, because those people do have good information, and the CDC has issued very clear guidelines about this.
Great. And along those lines of immunosuppression or not, which is actually a recurring theme that we get in terms of questions that obviously naturally people that have gone through breast cancer treatments have. So I have a couple of them. I think it was implicit already or explicit in your answers, but I think it's worth it just to re-emphasize the answers to these questions. So the first one, and they all are in that same, kind of, am I immunosuppressed or not if I'm giving this? So the first one is, I am 4 weeks post-bilateral reconstruction. Would you classify my immunity as low risk for contracting COVID-19? I think they meant high risk, but similar.
So your surgery alone does not make you immune suppressed. So I wouldn't be able to speak to their risk for, it's not a risk for getting COVID. I mean, everyone, because there is no immunity, because no one has immunity, everyone is at risk for getting COVID. That is why we're social distancing. The hand washing is considered so important. The wearing of a mask is now pretty much routine in most places. So everyone has the same risk of getting COVID, which is if you're exposed to COVID, you're going to get COVID because nobody has immunity. The real question is, what's my outcome if I get COVID? And that depends on when your last chemotherapy was. Did you get radiation? Are you on immunosuppressive medications? Surgery is by itself is not an immunosuppressive state. So if your only intervention was surgery, then your outcome from COVID, if God forbid you got it, is the same as everyone else based on your age and your other comorbid medical conditions.
Great. I have 3 more questions really along those same lines. So just, to help people that are listening. And these are questions that were submitted ahead of time. So the first one, I've had 30 rounds of chemo, a mastectomy with 5 lymph nodes removed and 30 rounds of radiation and have scarring on my lung from it. I'm on tamoxifen. I guess the question is, am I at high risk? But I hear from you that anybody is at the same risk, but also kind of, the outcomes.
Right, and I think it depends on when she had her chemotherapy and her mastectomy and her radiation, because people can be on tamoxifen for 5 and 10 years. So if you had this done if you had your chemotherapy and your surgery and your radiation more than a year ago, you are not immune suppressed. If you had this done, you finished your radiation 2 weeks ago, yeah, you are immunosuppressed. So if you have any concerns about that, you should call your oncologist and they'll be able to guide you. But again, it doesn't increase your risk of getting COVID. Everyone who's exposed has a risk of getting COVID because no one has immunity at this point.
Great, thank you. Another question also that was submitted ahead of time. I had a lumpectomy to remove 8mm IDC from breast. Nodes are negative. Am I considered immunocompromised now or when I start local radiation?
So from that kind of cancer and that kind of surgery, no, you are not immune suppressed. Radiation has a small amount of immunosuppression, and this is why the American College of Surgeons and the Association of Breast Surgeons have recommended for women with small tumors who have had surgery that they begin endocrine therapy if they're estrogen receptor positive and delay radiation until the pandemic is over. And again, that is a very acceptable and standard way of doing things. So it's entirely possible if this woman has an estrogen sensitive breast cancer that she'll be offered tamoxifen or an anastrozole now and to delay her radiation. We know that radiation should be initiated within 6 months of your surgery, but there's no difference between now and 6 months from now. And why are we delaying radiation? Because we don't want people having to come into the cancer center or the radiation facility Monday through Friday for 4 to 6 weeks. It just increases people's risk. It decreases your social distancing. And so we're trying to delay all the favorable risk patients until such time as the pandemic begins to wane. If this is a triple negative breast cancer, we won't wait. Again, for all the reasons we talked about at the beginning.
Yeah. One more question on this, and then there's a couple of follow up to this, actually different questions, but I'm trying to kind of put them all together. So am I more susceptible to the coronavirus or any other virus for that matter if I've been done with chemo since December, but I'm still on a maintenance treatment plan with Herceptin and Perjeta?
It's a very interesting question, and I think we don't know the answer to that. I think that's a very interesting question, and we don't have enough data to be able to say with certainty one way or another. I have patients in this situation, many of them, and basically I tell them the only time you should be coming out of your house is when you come here for your Herceptin and pertuzumab. We are exploring doing more and more home chemotherapy, as are many institutions across the country, particularly for people who are very stable on medications like these two. These are not the only medications we're looking at. We're looking at other medications like pembrolizumab that people get for lung cancer and for melanoma, and trying to do those at home simply to limit contact. But I tell patients getting Herceptin and pertuzumab trastuzumab and pertuzumab, the only time you leave your house is to come here. Everything else is stay at home.
And it will be the same, because we got this question live just now, for Herceptin only?
Yes, I think I mean, I think it's going to be less, but I think I don't know. Because there is no data to be able to guide us in this. This is really a data-free zone. And like I said, you know, we only have the experience of China and Italy right now. And China and Italy, just so everyone knows, were incredibly transparent with who got COVID, how they did, what their ages were, what their comorbid conditions were. But they're still caring for patients. So they haven't sat down and aggregated their data and thought about their data in a systemic way. They're a couple of weeks ahead of us, but they're not a year ahead of us. So the fact we have any data at all, the fact that there's more than one article in the New England Journal and the Journal of the American Medical Association every single week is amazing, that people have had the time to take pen to paper and get this information out.
Great. You know, somebody picking up on just the comments that were just made, they say, okay, I understand everybody's at risk, but does the risk increase if you have had chemo or radiation recently?
The risk of death from COVID increases. The risk of contracting COVID is 100% for everyone in the population.
Okay.
There is no human on the earth, unless you've had COVID, that is immune to COVID. And if you're exposed and you have the virus, if you get the virus in your eyes, your nose, your mouth, you've got COVID.
And how are I mean, patients that are hospitalized today and that have had breast cancer and have contracted COVID being treated?
So they're treated, if they're hospitalized, they're treated the same way as everyone else. There's no special treatment if you're a cancer patient or you're a dialysis patient or a heart disease patient or, you know, Joe Blow off the street. Everyone is treated the same. The vast majority of patients will never come to the hospital. Well, they'll have symptoms that can be managed at home. For those people who come to the hospital, a small percentage of them, as you can see, you know, it's a small percentage, about 20%, will require ICU. And then a smaller percentage of that require ventilators. So just because you're in the ICU doesn't mean you have a ventilator. Just because you're in the hospital doesn't mean you're going to do terribly. But if you're sick enough to be in the hospital, that is a very scary place to be right now. And we don't know why some people get better and some people don't.
Okay. Maybe last question on this topic. I am 4 weeks post-bilateral reconstruction, sorry. Would you classify my immunity as low risk of contracting COVID-19? I may have asked you this question already, actually. Yeah, sorry. Sorry. I just want to make sure I'm answering every question we're getting. So let me now go back to people that are actually just active because of a number of things. So we have a number of people that actually are on clinical trials. And so when they're on clinical trials, they're being treated. We've got this very specific question that came through a couple of days ago, and I'll read it the way it came. So I recently started the Natalie clinical trial, being that ribociclib lowers white blood count, and the trial requires 2 times a month clinic visits. Do you feel the risk of participating during the pandemic outweighs a potential benefit?
Yeah, it's a trial I'm very familiar with. I have several patients on this trial, and this is a conversation I have with patients every day. You know, this is what we have to do with the clinical trial. This is the anticipated benefit, but we have the reason we do trials is because we do not know what the outcomes will be for those patients. So this is a conversation that you need to have with your physician who put you on the clinical trial, and every patient will come to a conclusion that makes the most sense for themselves. Okay.
We have one more question, also a couple more questions that came before the webinar. So one of them, which I think you touched on it, but I just want to make sure we address it directly, is Are there any emerging COVID-19 survival statistics specifically relating to those who are in active treatment for breast cancer?
No, we do not have that data. The data we have, the emerging data we have about patients who do poorly with COVID tend to be from, and cancer, tend to be from patients with advanced cancer or patients with lung cancer specifically. Makes sense, it's a respiratory virus. People who have compromised lung function probably won't do as well.
Okay. Another question we got, I'm due for my restaging PET scan. I'm stage 4 de novo bone mets, 4 years so far. I'm afraid of COVID-19 and due soon to get the scan. Should I risk going for scan to check on my cancer? My doc has hundreds of patients. I'm getting standard answers of getting scan and it's bad than met with doc, so not sure what to do.
So, you know, I mean, it's hard to know. If you've been stable over a period of time, then you can consider delaying it. And again, I have patients that have called me and said, look, I'm just not going to have the scans right now. There are some patients, I pick up the phone and I call them and I say, really, it's important for you to have a scan because there are some real, we're at a crossroads and we need to make decisions. And there are other patients where, you know, I know they're going to be okay. They know they're going to be okay. And the other thing to also speak to your providers about is whether you could potentially, you know, have lab tests done and have them done closer to home at a facility closer to home rather than having to come into the healthcare system. Those are questions I get all the time as well. And you know, we make accommodations for people all the time, but I think that's really, most patients have a sense of how they're doing, and if they're anxious to know how they're doing, they'll go forward for the scans. And if they know they're feeling pretty good and they've been on the same medicine for a long period of time, a delay of a couple of weeks until the surge settles down is likely to be reasonable. But again, this is really a question that, you know, this is a shared decision between you and your provider. There's no right answer here.
Okay. Another question we just got through the live stream. Stage 4 people are worried about being denied a ventilator if they get COVID and it comes to that. Any perspective? I know there's been issued some guidelines, in particular in New York. I don't know if it's also in Massachusetts, but can you speak to that? Yeah.
So we have had decision-making and crisis situation guidelines in place for several years. I can speak to the decision-making in Boston and in Massachusetts, and the Department of Public Health has issued, the statement. It's in the press. It was in the Washington Post and the New York Times, and it's been around. The first line of every statement, because these are consensus guidelines that have been drawn from ethicists, physicians, patients, advocacy groups, lots of stakeholders, medical ethicists, is no patient will be denied a ventilator on the basis of their diagnosis. Now, there are, when ventilators are scarce, when there are 20 patients in the emergency room and 2 ventilators, which is a place you hope never to be, then the patient's entirety begins to be looked at. Age, comorbid conditions, likelihood that they'll be alive a year from now, those kind of things. Then there are scores. They're called SOFA scores. And so it's really the likelihood that you would come off a ventilator. So there are many patients that come to the hospital, cancer, no cancer, who you know, the likelihood of them coming off of a ventilator is very, very low based on their underlying medical conditions, not just breast cancer, but heart disease, marginal kidney function, age, other major medical illnesses that, you know, in a normal time, you'd put them on a ventilator and hope for the best. But in a crisis situation, those kind of things begin to get weighed. And you can go to your Department of Public Health in any state that you're in. These are now posted and publicly available. So just based on your diagnosis, the answer is no. There is no patient will be denied based on their diagnosis. But if a crisis situation is, and this will be transparent, it'll be communicated to the public through the Department of Public Health, that we are now using criteria for who will get a ventilator and who will not, then you can look to see what the criteria are. And, you know, we hope we never have to get there. So far, no state has enacted this that I'm aware of. I think New York came pretty close, but I don't believe that they actually did. I think, and the other part of this is the decision about if we get to this point, the decision is not made by one physician. It's made by a triage team. It's not made by the physician in the emergency room. It's not made by the medical oncologist who knows this patient. It's not made by the person who is working on the unit that you're admitted to. This is done really by a triage team. And the reason for that is the moral hazard for the patient, the family, the treating physician, the physician who's standing right there. It is too great. So it really does need to be a distributed and consensus opinion.
Great. I want to come back now to, you know, kind of being diagnosed with breast cancer in this context, or even, you know, more broadly, but in this context. So if you're a woman newly diagnosed with breast cancer of a childbearing age, and, you know, ultimately, you know, you're going to need to get treatment, you are interested in doing, you know, kind of preserving fertility in one way or the other, you know, obviously egg cryopreservation is an option. How would you, what would be your advice, or, you know, kind of, you know, what has been the practice, if at all, has changed in this context, but also more broadly, perhaps, you know, kind of, you know, how does somebody think through this, and what are the options they have in terms of preserving fertility?
Great question. It varies depending upon what resources are available to you. So, you know, in Boston, we are very fortunate to have multiple reproductive endocrinologists who are very committed to doing egg harvesting and embryo, you know, in vitro fertilization for women. I think that one of the big things right now is that starting chemotherapy for a woman right now during the COVID crisis is taken very, very seriously. We are trying to not start chemotherapy unless there is a compelling reason to do so. So it's chemotherapy that causes infertility. So delaying chemotherapy using endocrine therapy is one option. The other is for those women who have to begin chemotherapy, it's really exploring the options that are available to you in your current situation. At this time, we are very limited in what we can do for egg harvest, simply because we do not have OR time to do that. And so this has been a difficult conversation with the few patients that it has come up, and I suspect it will continue to be a difficult conversation. If patients need to start chemotherapy to save their own life, then they have a decision to make. Do they delay life-saving chemotherapy for fertility, or do they go forward with their chemotherapy using a variety of different endocrine maneuvers to try and shut their ovaries down and try for and hope for fertility after chemotherapy? These are very difficult decisions. There again, this requires a multidisciplinary conversation with the reproductive endocrinologist and the medical oncologist and the patient.
Okay, I do want to, because we've touched in the multiple parts of this discussion on the options aside of chemotherapy, and obviously the examples I've heard is like hormone treatments for hormone positive breast cancer, HER2 targeted therapy for HER2 positive breast cancer. What are the real options for triple negative? And can you kind of give us a sense, is it like you have to get chemo no matter what, or are there like contexts in which chemo is actually optional in the context of triple negative breast cancer?
Many medical oncologists believe that any woman with a centimeter or greater of triple negative breast cancer requires some form of chemotherapy. Whether that is done prior to surgery or after surgery is a decision that the medical oncologist and the surgical oncologist make together and recommend to the patient. If women who have a greater than a centimeter tumor, one of the benefits of giving chemotherapy first is that you then know who has a response to therapy at the time of surgery and who doesn't. Certainly, any woman with a tumor that you can feel should receive upfront chemotherapy. And the benefits of that makes the surgery less complicated for the women you can feel a mass, but in the smaller tumor, it really does tell us who responded to chemotherapy and who doesn't. That gives us powerful prognostic information. It also targets that patient for additional chemotherapy after surgery and radiation, which we have now shown does benefit patients insofar as survival. So there are really some compelling reasons to do chemotherapy first. Tumors that are less than a centimeter, that again starts to really become a shared decision-making discussion with your medical oncologist, because if you're very young, then yes, you'll benefit from this. If you have multiple comorbid conditions, it may not be likely we can get really effective chemotherapy into you. So it really does depend upon your stage.
And some of the recent developments for triple negative has been the immunotherapy drugs. These are never given in the absence of chemo or clinical trials where, an alternative to chemo is an option for triple negative breast cancer.
It's not an alternative to chemo, it's an additive to
an additive. Yeah, just to make sure it's clear, because we do get some questions like this. Maybe a couple questions and then we'll wrap up. If you do have any last minute questions, please put them on the Q&A. Otherwise, we're going to go for a couple questions and then move to closing. So also kind of broadening in terms of just, being diagnosed with breast cancer at an early age, whether, can you speak a little bit? So here I'm broadening beyond also coronavirus, but we do get these questions. A woman that is diagnosed with breast cancer before the age of 40 or at a very early age, is that always due to a genetic predisposition, or what do you any sense of the statistics or the likelihood of it being inherited versus de novo?
So it's not always genetic, and I think the usual things that we think about for genetic predisposition include age less than 50, a first degree relative, meaning a mother or a sister, someone in your family having ovarian cancer, colon cancer, or gastric cancer, or pancreas cancer, many men in the family having prostate cancer. These are things that make us think that it could be genetic. Women who are of Ashkenazi Jewish descent have about a 1 in 40 chance of harboring a genetic mutation. We know now that genetic mutations go well beyond BRCA1 and BRCA2. There are a variety of cancer predisposing genes, but age under 40 is not, it's higher likelihood that you'll have a genetic mutation, but it's not a guarantee. We know that sporadic breast cancer accounts for 85% of all breast cancers, in all age groups. We know that about 15% of women will have a family member with breast cancer, but of that group, only 3 to 5% will have an identifiable genetic mutation.
Okay, thank you. Maybe I want to end the last section around, things to, the good and the bad. And what I mean by that is kind of, we all, kind of are in this pandemic together. We all, whether or not have been diagnosed with breast cancer, have to deal with the possibility of contracting coronavirus. And so you and I have talked about this before around, anything that we should be doing today. Whether, I call it the good and the bad, meaning, kind of, on the good side, other than social distancing and kind of, staying in house, is there anything that we could do to maybe kind of, improve our overall health and, even in the context of potentially contracting the virus? But also you and I have talked about, just because unfortunately, if it hits, and depending on one's condition, it could go very fast. Whether it's kind of, having a will in place, or a number of things that, typically we don't talk about, but I think it's important to talk about them. I'd love if we can end with your perspective on this, and then I'll just give some closing remarks.
Sure. So first and foremost, stay home, stay home, stay home. Wash your hands, get your groceries delivered if you have that opportunity, or if you have to go to the grocery store, go during the times when they let the old folks go. Really, this is the key to flattening the curve. I mean, everyone has heard this now, and just protect yourself. I think that it's really important that people eat well, they get the rest they need. You avoid excessive alcohol. It's tempting. I chuckle that I'm going to be 40 pounds heavier and an alcoholic when this is over. But
You're not the only one.
Thank God for the Peloton and the on-demand exercises. I do want to just stress to cancer survivors, we know that exercise is critically important to prevent recurrence. And so 30 minutes of some sort of exercise per day. If you're getting out for a walk, pick your times when you know your neighborhood's not going to be crowded. Wear a mask, make one, buy one, however you cover your face. But if you can't get outside, you live in an apartment building, you live in New York City, you live in downtown Boston, it's busy. There are a million different ways to exercise in your home. You have on-demand options through your cable provider. You have a variety of different platforms that are offering free exercise. The YMCA in many places is offering free exercise videos that you can access on your phones. If you're accessing Zoom, then everyone has a camera-enabled phone. Peloton is providing a period of time where their app is free. Core Power Yoga is doing the same thing. So there are a myriad of options available to people to exercise. So I would do that to prevent recurrence of breast cancer, but also for your mental health. It just makes you feel better to exercise. I think the issue about talking to your family and making clear what your wishes are. God forbid you got coronavirus and you were sick enough to be hospitalized, is critically important. When this virus got going, sometime in February, I have 3 daughters. They're all adults. They're all married. I have a granddaughter and one on the way in 3 weeks. And if that doesn't give you argida. And I sat down with them on a video conference, a group FaceTime, and said to them, listen, your mom's going to be taking care of patients with COVID, and I'm 62, and if I get sick, this is what I want, and this is how it's going to be, because I knew at that point that if I was in the hospital, there would be no visitors. It hadn't been made public at that point, but we all know from a public health perspective that this was going to happen. So I explained to them, if this happened, you cannot come to the hospital to see me. You will not be able to come to the ICU. God forbid I'm there. And if I die, you may not be able to have a funeral. And I made it so clear to them what my wishes are, because I'm also widowed, so I'm who they have. And we hate to talk about this, but we're all going to die. And we want to unburden the people who love us so that you've opened the door to conversation. They're able to share their fears about this, but you're also able to empower them to know what to do in the case that the worst actually happens. And despite the fact that there were a lot of tears, now 3 weeks, 4 weeks later, they're telling me that they're really glad they had this conversation, and they wish that their husbands' families would have this conversation, and they wish that their friends' families had had this conversation, because they really feel that they've been unburdened about their worry about what would happen if mom got sick. Now they know what would happen if mom got sick. And knowledge, just like knowledge about your breast cancer is powerful, knowledge is power when it comes to scary situations.
Yeah, and I mean, I have to say, I think when you and I talked about this earlier, I don't think we talk about this enough. I think, like hearing it from you, and then it made me really think about this. I think these are very important things that, maybe are difficult to talk about, but are very important to talk about. And I think so I want to also personally thank you for sharing this with all of us, because in some sense that kind of, perhaps give us all, the courage to have, these kind of difficult conversations too.
Look, death is not optional.
Right.
It's not
Yes,
optional.
unfortunately not. Yeah.
And no one, we don't get a stamp on our heel the day we're born that says we have, 84.3 years or 92.3 years. We don't know when it will happen for any of us. The key is living our best life. And that's what I talk to my advanced cancer patients about all the time. Stop worrying about when and think about, how do I live my best life today? And it's hard to live your best life when you're socially distancing from the people you love. I said goodbye virtually, in person to my pregnant daughter over 4 weeks ago. Do I FaceTime her every day? Do I read my granddaughter a book every day? Absolutely. But it's not the same. This is not what I would want for my best life, but this is the best I can do today. So you want to seize what you can today.
So thank you very much. So on this note, I want to, first of all, thank you, Dr. Mulvey. I think, this has been extremely helpful to all of us. And thank you for your time. I want to thank everyone. Thank you all for taking the time to join us. If you do have any follow-up questions, or if we didn't get to any of your questions or thoughts, please email us at COVID19@outcomes4me.com. We will also be sending out a survey after this. You'll receive it tomorrow for feedback on what you would like future webinars topics to cover. We will be doing this on a regular basis. And we will also be making these videos available on our website, outcomes4me.com, with a blog recap if you want to revisit the video or share it with others. To make sure you don't miss any future updates, make sure to have your push notification turned on within the Outcomes4Me app, as we will be notifying every time we're doing these webinars and other events. Thanks again. Thank you, Dr. Mulvey. Thank you, everyone, and stay safe. Thanks.